Hello, my name is Wagahta Semere. I am a scholar with the Center for Aging in Diverse Communities at the University of California, San Francisco. I will be sharing results from my project, Caregivers Matter, Secure Messaging in a Diverse Older Cohort of Patients with Type 2 Diabetes. Over the last few years, the coronavirus pandemic has accelerated our reliance on remote communication in healthcare. For patients with chronic diseases, like diabetes, that rely heavily on self-management and frequent communication with providers, these platforms have great potential for improving care. About a third to half of patients with type 2 diabetes are registered on portals. There is emerging evidence that when they engage on portals, they can experience better outcomes, like medication adherence and self-efficacy. Imagine, for example, a patient with diabetes who can email their doctor to discuss adjusting their insulin before their blood sugar gets so low they end up in the emergency room. Yet we know that older populations and communities of color are less likely to sign on to the portal and access its potential benefits. For those who do sign on, we know little about variation in their use of these platforms. Engaging caregivers may be a strategy for mitigating disparities in portal access and use. Over 40% of older adults on the portal report providing access to a proxy user. This can be an adult child, spouse, or other caregiver. But we know very little about how proxies engage with portals on patients' behalf. Understanding proxy portal use is a crucial first step to improving care delivery, patient outcomes, and guiding policies for family-centered care. The objectives of this study are to describe sociodemographic and clinical characteristics of patients who engage proxies in secure messaging, and to examine if features of secure message use vary based on patient sociodemographics, clinical characteristics, and proxy use. The study sample is drawn from the well-characterized diabetes study of Northern California known as DISTANCE. DISTANCE is a longitudinal study of social behavioral factors associated with disparities in diabetes-related care and outcomes among patients receiving care within Kaiser Permanente, Northern California, a large, fully integrated healthcare system. DISTANCE was launched in 2005 and has followed over 20,000 respondents with type 2 diabetes. The group is racially and ethnically diverse. 17% of participants self-identify as African American. 18% is Latino, and 23% is Asian or Filipino. Over 60% of respondents report having limited health literacy. Kaiser launched its patient portal in 1999, making it among the earliest adopters. The system incorporated secure messaging in late 2005, and in 2006 launched a feature that allowed caregivers to create their own portal accounts linked to the patients that they care for. We collected and securely stored all messages exchanged among patients 50 and older in the DISTANCE cohort over a 10-year period from 2006 to 2015. This is a first of its kind data set that allows for a retrospective longitudinal evaluation of nearly 400,000 messages involving patients, their proxies, and their primary care providers. There are 3 key steps to our methods that I will describe in further detail. First, we identified whether proxies were involved in patient messaging. Second, we defined 3 key features of message engagement: initiation, volume, and exchange. Third, we examined whether features of secure message use varied based on patient sociodemographics, clinical characteristics, and proxy use. One fundamental analytic issue that we had to address was how to identify messages written by a proxy. Proxies can access the portal in one of 2 ways. The first is by creating a registered user account linked to the patient. And the second, more common way to access is by sharing a patient's login. This second informal login method presents a challenge for identifying and characterizing proxy messaging. We were able to address this challenge by developing a novel computational linguistics algorithm to detect informal proxy messages. This algorithm was developed by identifying combinations of words and phrases more likely to occur in a proxy message than a patient message. This includes third-person pronouns and phrases like, "I am writing on behalf of." I'd like to walk through 8 steps that we took to develop this algorithm, which we named Proxy ID. First, we identified messages written by a registered proxy. Next, we randomly sampled an equal number of presumed patient-authored messages. Then we selected n-grams. These are words and phrases that were more likely than chance to occur in registered proxy messages compared to presumed patient messages. We then identified the frequency of these n-grams in each message presumed to be written by a patient. Next, we classified each of the non-registered proxy messages as predicted to be written by a proxy or predicted to be written by a patient based on the presence of the n-grams we identified. Then we selected 100 messages that Proxy ID classified as proxy-authored messages and 100 that it classified as patient-authored messages and validated them using human ratings. 3 blinded experts determined the proxy status of the same sample of 200 messages. We then determined the concordance between the expert assessors and Proxy ID. Proxy had a kappa of 0.58 and demonstrated excellent ability to exclude non-proxy authored messages, but the lower specificity suggests it likely misclassified some patient-authored messages as proxy-authored. Applying Proxy ID to the study cohort, we found that only 3% of patients had any messages written by a registered proxy. The rest of the patients had messages that were written under their user login, so were presumed to be written by the patient. However, when we applied Proxy ID, we found that 48% of patients likely had some of their messages written by an unregistered or informal proxy. Looking now at the proportion of patients' overall messages that were likely written by a proxy, we found that for 20% of patients, more than half of their messages over the entire study period were likely written by a proxy. More commonly, proxies wrote some of patients' messages, but not the majority. Here we're comparing the demographics of patients who did and did not engage proxies in messaging. Older patients were more likely to have a proxy when compared to younger patients. We also found racial and ethnic differences and communication differences in proxy use. For example, Latino patients were more likely to have proxies, whereas African-American patients were less likely to have proxies. And proxy use was more prevalent among those with limited English proficiency. When we look at patient baseline clinical characteristics collected in the 12 months prior to first messaging, we see that those with proxies have more comorbidities and more frequent utilization of the healthcare system, including outpatient visits, emergency department visits, and hospital admissions. Overall, it appears that patients with proxies are a more socially and medically vulnerable group. In order to look at messaging volume and exchange, we first characterize overall messaging for the sample over the study time period. We define messaging in terms of active use. Patients are all followed beginning in 2006. However, each patient begins messaging at a different time point. We were interested in following the volume and exchange of messaging once patients initiated messaging. In other words, when a patient became an active user. We determined total person months and person years contributed by active users in the study cohort. We accounted also for dropout when patients left the health system. As you can see, there is a trend where we see significant gains over the years in patients that are messaging, and use begins to level out somewhere around 2011. The key message features that we were interested in examining were initiation, time to first secure message from study onset, volume, annual number of secure messages sent or received, and exchanges, annual number of secure messages with at least one reply. Other message features that we explored included threads, annual number of secure messages with new subjects, and exchange length, the average number of secure messages within an exchange. Patients who engaged proxies to any extent compared to those who did not exhibited more messaging engagement when examining frequency and interactivity of messaging. This included overall messages sent or received, messages sent by patient or proxy, messages sent by provider, threads, exchanges, and exchange length. We found racial, ethnic, age, and communication disparities in initiation of secure messaging. Older patients were slower to initiate compared to younger patients. Non-white patients were slower to initiate compared to white patients. Those with less education versus more education, and those with limited English proficiency versus English proficiency were slower to initiate messaging. Proxy use was independently associated with earlier initiation of messaging. Patients who appeared sicker at baseline, as evidenced by having more comorbidities, worse diabetes control, and more frequent ED visits, were slower to initiate messaging, whereas those with more engagement with outpatient visits initiated messaging sooner. Next, we examined overall volume of messaging. Similar to initiation of messaging, we found racial, ethnic, age, and communication disparities in volume of messaging. Older patients had less volume of messaging compared to younger patients. Non-white racial and ethnic groups had less messaging compared to white patients. And those with limited English proficiency had less volume of messaging compared to those with English proficiency. Proxy use was independently associated with greater volume of messaging compared to no proxy use. Patients with more comorbidities and healthcare utilization at baseline messaged more than those with fewer comorbidities and less healthcare utilization. Once again, when we examined number of exchanges, we found racial, ethnic, age, and communication differences. Patients who were older had fewer exchanges than those who were younger. African American, Latino, and Filipino patients had significantly fewer exchanges compared to white patients. Patients with limited English proficiency had fewer exchanges than those who were English proficient. And having a proxy was independently associated with more exchanges compared to not having a proxy. We found that having 3 or more comorbidities at baseline and 3 or more outpatient visits over the past year was associated with having more exchanges. I would like to note 3 key limitations of this study. First, Proxy ID has excellent ability to exclude non-proxy messages. Specificity was limited, so some patient-authored messages might be misclassified as proxy-authored. When examining our outcomes, we focused on any proxy involvement, as opposed to comparing differing degrees of proxy involvement to limit any bias this might introduce. Second, we accounted for patient baseline clinical characteristics. Considering time-varying clinical characteristics may have led to some differences in messaging outcomes. And third, we compared non-proxy users to users with any proxy use. Proxy effect may have differed over the course of the study period and based on the overall degree of proxy involvement in messaging. Despite these limitations, we can draw important and novel conclusions from this study. Among a diverse cohort of older patients with type 2 diabetes, those who had proxies initiated messaging sooner and with greater frequency and interactivity. Therefore, exploring strategies to better equip caregivers to participate in messaging may help to address socio-demographic disparities in accessing potential benefits of messaging in diabetes care. Thank you.